Okay, good afternoon, everyone. This is the Health and the Public Interest Master's Program, starting off its seminar series with a special guest who is actually one of the instructors in the program. He will be introduced momentarily by one of our students who's the moderator for this morning. I'd like to just point out that the Health and the Public Interest Program is a master's program, an official offering of Georgetown University. Jennifer is going to put the URL in the chat in case you want to see what we're all about. But basically, we're a program that looks at health and public health from the standpoint of social determinants, influences of all kinds of factors, including economic factors such as today, but also things like more like influence of drug companies, pharmaceutical companies, social, ethnic influences, et cetera. So we're a wide-ranging program that looks at practically everything that affects health except for the actual clinical practice of medicine for the most part. I'm happy to see some of our regular outside visitors, so welcome back after a long hiatus. We have a lineup of 12 seminars this fall, and I think you'll find them to be our usual interesting fare. At least I hope so. And the way this seminar is going to work is, as usual, there'll be a introduction by Abba Mantri, our student moderator, who will tell you a little bit about Dr. Vincent Turbat, and then Dr. Turbat will speak for about 40 minutes, and that'll be followed by a question answer discussion period that'll first be um, involve students and then the greater audience. So stick around if you have questions until the appropriate time. And, since this is a graduate program, we also suggest that our students think about questions that are related to careers and the fields that we're talking about during these presentations. So without any further ado, Ava, thanks so much for the brave volunteering of being the first moderator of the year.
Thank you, Dr. Myers. Good afternoon, everyone. My name is Abba Mantri. I hope everyone can hear me okay. So it is my pleasure to introduce Dr. Vincent Turbat, Associate Professor in the Department of Global Health at Georgetown University School of Health. Dr. Turbat began his career in economics at the University of Saint-Étienne in France, where he taught and conducted research for nearly 2 decades with a focus on macroeconomics, growth and development, and health economics. In 1991, he joined the World Bank as a health economist, where he designed and led learning programs on health financing, health sector reform, pharmaceuticals, and HIV/AIDS. He later moved on to the operational side of the World Bank, where he's served in both East Asia and Africa. And from 2003 to 2006, he was the World Bank country manager for Niger. Since 2010, Dr. Turbat has been at Georgetown University, where he teaches courses on health economics, health financing, and global health systems, while continuing his research and consulting in healthcare financing and digital health. He holds a PhD in economics from the University of the Mediterranean, Aix-Marseille, and graduate degrees from the University of Paris and the University of Orléans. To get acquainted with Dr. Turbat better, a fun fact about him is that he never applied for a position at the World Bank. They reached out to him, and in a similar fashion, he never applied for a position at Georgetown University. They reached out to him. And since we have some avid travelers in this cohort, another fun fact is that Dr. Turbat has traveled to 111 countries. So please join me in welcoming Dr. Vincent Turbat.
Okay. Thank you so much, Abba. Okay, so today we are going to talk about health system performance. So I'm going to share some slides with you. Okay, do you see the screen properly?
Yes, we can see it. Yeah.
Okay, very good. And so, say, measuring what matters, health system performance unveiled, means that when we try to assess the performance of a health system, we need to look at different kind of indicators. So the first thing to mention is that performance is measured by the extent to which the core goals are achieved. But sure enough, it depends on these goals. And if you look at the US system, you would say, okay, if the goals are to enrich the health insurance companies or the pharmaceutical companies, the performance of the health system in the US is number one. But if the goal is different and we can select the goal that is today highly accepted in the world, which is universal health coverage, we are going to see that it's another story. So what does that mean to try to reach universal health coverage? It means that everyone has access to the full range of quality health services they need when and where they need them without financial hardship. And this example of without financial hardship, I like to give this example that while in Lao PDR, I was surveying the project on malaria. And I met with people in the field. And I remember this farmer telling me, you know, my son had severe malaria. And what I had to do is either I had to sell my cattle, especially their water buffalo, to bring their kid to the hospital. But doing that would have put the whole household, the other children, the parents, at risk of not having any food. So he said, I chose a dilemma of choosing between the household or the life of a kid. Also, what is important to highlight is the fact that universal health coverage is about the whole continuum of essential health services, health promotion, prevention, treatment, rehabilitation, palliative care. All these health services should be accessible to all the people in a community. Okay, so if this is the goal that we are looking at achieving, so first thing that you need to do is to enhance the health of the general population. So how are you going to measure this increase in health of the general population? But the common indicators that are used are life expectancy. We know that today, when you look at the world, you have huge discrepancies in life expectancy. For the developed countries, it's generally above 80, and for some developing countries, they are still under 70 years. So huge discrepancy. Another indicator would be a healthy life expectancy, what is called HALE, H-A-L-E. And this, if the life expectancy measures the number of years that you can expect to live at some age, as you know, life expectancy is different at different ages. For one good reason is that the mortality rates in neonatal infant and child are extremely high. So if you are able to go beyond 5 years old, then your life expectancy is increased. So life expectancy, it's the difference between the number of years, that you can expect to live at some age. But the healthy life expectancy is the number of healthy years of life that you can expect to live at a certain age. So that's first element. What else you can look at for the health of the general population? Mortality. As we said, the mortality rates, neonatal, infant, child mortality are extremely important. Then also the maternal mortality ratio, not rate. And I'm sure you know that the difference between rate and ratio is that in a rate, you have the same population at numerator and denominator, whereas you have a different population at numerator and denominator for a ratio. So it's why for maternal health, which is the maternal mortality, which is the number of deaths of mother per 100,000 live births, children, but it's a ratio, it's not a rate. Okay, what else? We look at the traditional epidemiologic indicators, prevalence, incidence. And you know that you have to be careful using one or the other. An example is in a HIV/AIDS program, and it's what we were doing at the beginning, we were using the indicator of prevalence. And so at some point we saw reduction in prevalence. Yeah, but this reduction of prevalence was not due to a diminution in, a decrease in the incidence, but it was due to the death of people with AIDS. So you have to be careful when you use these indicators to make sure that they are providing the right information. So another indicator that I consider important is the DALYs in rate terms. What are the DALYs? The DALYs are the disability adjusted life years. It means that what you are looking at is the number of life years that are lost as a result of a disease, okay, either because of death or because of disability. So how is it measured? For example, a person dies from malaria at 2 years old, and the life expectancy in this country, let's say, is 70. Well, it's 68 years of life that are lost. But then if you have a disease, for example, an AVC, and you don't die from an AVC, but you are disabled, then the number of years that you are going to live are not counted as full years of life. Okay? So the DALYs, it's the sum of life years lost to death or life years lost to disability. Okay? So, and if you take DALYs in the rate term, it's because if you look only at the sum of DALYs lost to a disease in a country and you compare to another country, it doesn't make any sense because it depends on the size of the population. But if you take the rate, which is DALYs lost per 100,000 people, then you are able to compare things among countries. Where do you find these DALYs? Mostly on a website called IHME. And IHME measure the DALYs in the world, and it provides you the DALYs lost per disease in all the countries in the world. So I highly recommend to use the IHME website for assessing the DALYs lost. They also provide the death due to a disease per country. Okay, so that's the first goal. You need to improve the health of the general population. The second element is accessibility. And as you know, accessibility is not rich in many countries. So we distinguish two kinds of accessibility: the geographical accessibility and the financial accessibility, which is also called affordability. Okay, so accessibility, geographical accessibility, as you know, the coverage is very low in some countries. For some people, the closest health center and closest district hospital is sometimes more than a day. So there is no accessibility, and we need to develop this accessibility, geographical. And the second is affordability. As you know, health facility. But at the end, we realize that for the population, the cost for a malaria episode went from 7,500 Ouguiyas, the Mauritanian currency, to 450 Ouguiyas. So by having a mandatory payment system, you were helping the population. Why? Because the so-called free services, free health services, was not free because people had to pay under the table and a lot. And if they needed pharmaceuticals, they couldn't get their drugs in the health facility. They had to go to the private pharmacy where they couldn't find generic, but only brand names. So they had to pay much more. And that explained why with this cost recovery system, the system became more affordable and more accessible for all. In addition, there was an exemption payment for the poorest of the population. So, third element, we need to improve cost effectiveness. So when we say to improve cost effectiveness, it means two things. The first one is we want to improve the technical efficiency. Technical efficiency means that you want to be able to provide services, health services, in the most cost-effective way. In cost effectiveness, you look at, for example, how much will it cost to avert a DALI? Okay, so you can compare this all over the world. What does it cost to avert a DALI in malaria, in TB, in HIV/AIDS, whatever? Okay, but this, you want to be as effective, as cost effective, sorry, as possible. And what we can see is today, a big boost on cost effectiveness comes from digital health. Digital health is the future of health and should help reduce the cost drastically. But the second aspect of cost effectiveness is what we call allocative efficiency. So what does that mean, allocative efficiency? It means providing health services that best meet societal needs and maximize health outcome given the available resources in the country. Okay, so here you want to deliver cost-effective services, but where they are needed. And believe me, in my career at the World Bank, I've seen many times, for example, the drugs for HIV/AIDS in regions that had a very low incidence of HIV/AIDS, and but having a lot of malaria drugs and that they didn't need. So you need to have the services where they are needed. And this implies to have a correct health map. You want to be able to map where are your services, where are the equipments, and where are the diseases. In some countries, HIV/AIDS is in pockets, malaria is in pockets, TB is in pockets. Means that it's not spread in the country, but it's in some defined areas. Next, you need to improve responsiveness. We know that some health services are not responsive. And if you look at the satisfaction of the population with regard to the services, you notice that very often this satisfaction is extremely low. Why? Because the systems are not responsive. Then you need financial protection. And but the best financial protection is when you have mandatory health insurance, and this mandatory health insurance is subsidized for the poorest. Okay. How do you see whether there is financial protection or not? You look at an indicator that is called out-of-pocket payments. In countries where the social insurance works very well, this out-of-pocket is less than 10%. But in countries where there is very little financial protection, it's often higher than 80%. So if you don't provide this financial protection, you will never be able to develop an efficient health system. Citizen satisfaction, I've mentioned, because it's linked to responsiveness, but you want to improve this citizen satisfaction. Okay, so what are the indicators that are most used to measure this progress on performance? Well, first, longitudinal study, meaning time series. You want to compare the financial protection in 1980 to what it is today in 2025. And you follow what's happening. Okay, so I'm sure that you are used to time series. Second one is to do comparative studies. So comparative studies, it's between countries. But again, when you compare countries, you have to be extremely cautious. You don't want other elements to interfere in your comparison. So it's why taking a rate of DALYs lost is wise. If you take the absolute number of DALYs lost, you come to the wrong conclusions. You can compare also to average. So average in the region, average in the world, average among low-income countries, average among high-income countries. Or you can compare to a median, see where you are. Are you in the right position with regard to the performance? And then you have norms. I'm sure you know that WHO is publishing norms. So, for example, 5% of the GDP should be spent on health. 15% of the global budget, meaning the government budget, should be spent on health. That's the norm that the WHO is enacted. So DALYs, I've always mentioned DALYs. They are used a lot today, but you have others. You have life years. So you just look at the life years, or you look at QALYs. QALYs is quality adjusted life years. So QALYs are used when you want to measure the life years that an intervention has added in the population. And so it takes into account the quality. And if the quality is not 100%, because you have a disability, because you don't have your mobility or that kind of thing, then there are coefficients that you apply in order to measure the loss of quality of life. Okay? And these coefficients are provided by WHO, the World Health Organization. Again, mortality rates, and as you know, these mortality rates have been used as objectives for the Millennium Goals, for the Sustainable Development Goals. We are using these mortality rates and ratios. And then, as an economist, I'm using a lot of economic indicators, and these economic indicators I find in the National Health Accounts, NHAs. And these National Health Accounts you can find in the website of the World Health Organization, is who.int, or you can find in OECD database, World Bank database, some in IHME, Institute for Health Metrics and Evaluation. I've not spelled out the acronym last time. So, for example, CHE means current health expenditures, that are the expenditures that are renewed several times during the year, and you want to see the percentage of this CHE in the GDP. Okay. But if you do this, you have just a measure of the cost. But if you are interested in performance, you need to compare the cost to the health outcomes. Okay? So, for example, if you look at the US, you see that the CHE in percentage of GDP is 18%. Okay? And if you look at the health outcomes, you see that they are among the worst among the high-income countries. Okay? So, if you have a country spending a lot for bad results as compared to the other country, then it's clear that you don't have technical efficiency, you don't have allocative efficiency in this country. So let's go a little bit deeper on this. So we can, and I like this characterization of the US system. The US healthcare system's fundamental problems could be summarized as having too many bills, too many hills, too many pills, and too many chills. Catchy, isn't it? So let's look. Too many bills. Too many bills means that the American healthcare is the most expensive in the world. In 2023, the United States spent $4.9 trillion on healthcare. And if you look at the per capita spending, it's $14,570. And it's more than double the average of all the other high-income countries. So, as I said, 18% of the GDP. Most of the European, Japanese, Singaporean, they spend between 8 and 12% of their GDP on health. And for better reasons. So what seems the main reasons of this poor performance? Seems that there is first high drug prices. And this I can confirm because during my time at the World Bank, I was traveling a lot. And wherever I was going, I was checking on prices of drugs. And systematically, the prices were going from 1 to 10 between these countries in average and the US. When you were paying an inhaler $150 for asthma or kind of a respiratory problem, then this same inhaler was less than $5 in the other country. And the second is administrative cost. Administrative cost in the UK, for example, is 2%. Administrative cost in the US is close to 20%. So this is not possible. And I'm sure you know that Obamacare was trying to limit this administrative cost by enacting the rule of 80-20 or 85-15. But as you know, this has been abandoned, and therefore the administrative costs are on the rise again. Too many pills. Too many pills refers to the poor quality of care. Iatrogenesis, what physicians do or fail to do when treating their patients, causes approximately 400,000 hospital deaths each year in the States. So this is quite unacceptable. To think that these iatrogenesis causes are the third leading cause of death in the US. Adverse drug reactions, ADRs, are also very high and make this situation worse. So a lot of these deaths would be preventable. And it's why when you ask people what do they think about their health system, 31% say it is fair and 21% call it poor. Okay. Too many, sorry. So too many hills refers to poor outcomes. As I said, despite spending more than anyone else in the world, the outcomes are among the worst of all industrialized countries. So, and it's incredible to think that some indicators are still deteriorating with all the progress that have been done in health, that infant mortality can still increase in countries, that you have 5.4 deaths per 1,000 live births in the US, where it is only 1.6 in Norway. Well, definitely something is wrong with the US performance. Also, if you look at the maternal mortality, either looking at the rates or the ratio, there are, and when we look at this, here we're talking only about the average, but as you well know, these are extremely inequitable. It's much higher for African American, for Latino mothers. Too many chills refers to the fact that this system is unfair. And as I was mentioning, you have huge discrepancies in the way people are receiving health in the United States. And this is not improving. There are a lot of websites where you can see what's happening in the US. If you are interested, just shoot me an email and I will give you a list of websites where you can find these data and you can compare what's happening within the Latino, African American, white American, etc. It's quite interesting to see the differences. And as this person say, is also truly quite chilling. So how can you improve the performance of the system? But the first one, as an economist, that I would look at is incentives. Do you have the right incentives? Let me give you an example. There are three main systems to pay the health providers. You have user fees, you have payment per case, and you have per capita. What is the incentive if I am a health provider and I'm paid through user fees? My natural incentive is to multiply the number of services that I'm going to deliver, because each time I deliver a service, I'm going to be paid. So, do I have an incentive to deliver good quality service? No, because I want people to come back. Do I have incentive to do some preventive care? No, because I want the people to come and use my services. Now, if I'm paid per case, for example, someone comes to see me for a malaria episode, I treat the malaria episode, and the person is paying. If the person is coming back a few days after for the same malaria episode, I'm not paid again. So, and it's something that has been extended to hospitals. Hospitals, they are paid on the basis of DRGs, diagnosis related groups. And these payments are lump sum. So it means that even if you do more for one patient to another, you are paying the same amount of money. So you have a strong incentive to deliver good curative care. But do you have any incentive to do preventive care? No, because you want people to come back for other diseases. Okay? Now, if you are paid per capita, you receive a lump sum for the whole year. Okay? So what is your incentive? You don't want the patient to come back, because if the patient is coming back, let's say that your lump sum is 2,000. You're paid 2,000. Then the person is coming back. It cuts the sum by 2. So now it's 1,000. And then by 3, it will be 600. And then, well, okay. So you don't want your patients to come back. And if you don't want your patients to come back, they need to be in good health. So you need to do good preventive and good curative when they have to come to see you. Okay? So you see that if you want to contain the cost and at the same time provide strong incentive for quality care, you should definitely not use user fees, because user fees is a good way to make money for the health providers, but no incentive to deliver quality care or to deliver prevention services. Technical efficiency. You need to improve technical efficiency. And as I said, technical efficiency is to look at cost-effective ways of delivering a service, doing surgery, all this kind. And today, it's possible to conduct what we call cost effectiveness analysis, CEA, and this cost effectiveness analysis provide you with information about the interventions that you should implement. Some are much less cost effective than others. And so you don't want to use the less cost effective because you are wasting resources, and resources are scarce. Allocative efficiency, again, I explained what it was. Health system financing. You need to improve health system financing, which means that you need to cover more people and you need to cover a larger benefit package. An example that we have used in Cambodia, for example, is to develop what was called equity funds. Equity funds were developed at the level of hospitals or health centers, and it was to pay on behalf of the poor, okay? And this system worked so well that the government of Cambodia decided to have an equity fund at a national level. So you need to provide this financial protection without which people cannot access health services. Okay, so I'm going to stop here so that you can ask questions. I think that I've not been too much over my time. So, Abba, the floor is yours.
Thank you for that presentation. That was really insightful. Just to go over like something really quickly, I will be taking like student questions before general audience questions. So if anybody has something to ask Dr. Turbat, please go ahead and raise your hand or just unmute and go ahead. If not, I can probably. Okay, so
sorry, I was just going to say sometimes it takes the students a little bit the first week to get up the courage to ask questions. So I ask that people come up with, the courage to ask those questions. And it sounds like Ava had one to throw out there in the meantime.
yeah, I can start us off if that's okay with everybody. Dr. Turbat, a question for you is, having worked both hands-on and in research settings, what do you think that academics and like rising academics like us in this program, what do you think that we often miss when analyzing global health financing and policy?
Yeah. Okay, so what you learn is if you want to develop a good policy, you need to know what are the main issues. And the only way to know what are the main issues is to go in the field. Okay? So what I dream of is that we would have enough financing to send students in the field so that they can practice what they learn. Because I've been a professor before going to the World Bank. And if I compare the professor I was before and the one I am after, maybe I was better at theory before, but there was no flesh on the skeleton of the theory that I was teaching. Now I can really give examples of real life example. And to me, you have two kinds of economists. You have the economists that are making good models on a white sheet of paper. But you know what is missing? People. And for me, economy should be about people first. Okay? So now what I'm teaching is more what is needed for people to have a better life, a better healthy life.
Thank you for that answer. I'm going to pass it over to Taruni now. Go ahead.
Hi, can you hear me?
Yes, we hear you.
Thank you so much for your talk. It was really interesting to see how you broke down all the components of the health system. So my question was a bit more general. So I know earlier when Abba introduced you, she mentioned that you had traveled to over 100 countries. I was curious if there was a particular health system, maybe kind of similar to the US or just more opposed to universal healthcare that was able to actually implement some sort of cost-effective method or one of the methods that you mentioned in your talk.
Okay, so thank you very much for your question. I'm not going to say one country, but I'm going to talk about what should be in a health system to work efficiently. To me, the best is when you have public-private mix. Public financing and private delivery. But private delivery regulated. I think that what makes a whole difference is the fact that some systems are properly regulated, meaning that the providers cannot decide how much they are going to, as the patient, pay. The health providers are closely monitored with regard to the quality of the services they are delivering. And if they are delinquent, they can be kicked out from what is called the covenant. The covenant is a system in which you say, okay, I sign this covenant, and in return, all my patients are covered by the social security system. So I know that I will be paid, and that my patients will have no problem having the health services that they need, okay? But in return, I accept not to fix my own tariff, not to, and accept to be monitored, that the quality of my services are monitored. And I worked on a system like this in France, and what I discovered is that you are comparing the profile of a GP. For example, you realize that this family doctor is providing far more sick leave than another. Okay? So what you do, you ask, okay, why is it? What justifies this high number of sick leave as compared to the other family doctors in the region? And it's done by region, because, as you know, population in different regions can be very different. So, and if the family doctor cannot provide a good reason why, then they receive a warning. And after 3 warnings, they are kicked out from the covenant. So I think that a system where you have public financing through government budget or through social security system and private delivery, but regulated private delivery, you have the most cost-effective health system.
Okay, let's go with Molly next.
Hi, thanks so much for doing the first seminar. My question was because you talked about, like, in order to improve performance, you need to improve the responsiveness of the healthcare system. And I was wondering, like, how we can do that, given that we're currently in a period where there's like so much distrust about science in general.
Yes, it's definitely a big issue, this distrust, but we have to fight this distrust systematically to reveal all the lies, all the, stories made about vaccines, for example. So it's our responsibility as a health community to respond to these campaigns. Second, I think that what we need to do is really to develop a kind of dialogue between the health providers, the scientists, and other things, and the community. We have not been good at communicating, and therefore I think that we need to communicate better. I can give you an example of bad communication. This time it was in Indonesia. In Indonesia, the patients are systematically requesting an injection when they see their family doctor. And if the doctor says, no, you don't need it, it's considered as a bad provider. So within the Ministry of Health of Indonesia, we discussed how we could do something to lower the number of injections per visit. And I remember I left because I had to go in the province. And then when I came back, they said, oh, you are going to be happy. We found a campaign for this. And the campaign was an injection can kill. I say, guys, you are going to kill the immunization program. Are you? No, it's not the kind of communication. So I give this example to show that we miss communicators in the health system. And we need to work on good communications and to think that health messages are not simple. So we need to find ways to explain them very simply, in simple words. Okay? So it's not easy, and it requires specialists and it requires money. But at this point, we have not spent enough on communication.
Thank you so much.
You're welcome.
All right, I'm going to go to Sasha next.
Hi, yes, I also wanted to thank you for providing such a great explanation and such a great lecture. I was particularly interested in your explanation of dollies. This was my first time kind of getting to know what that term meant and being introduced to that term specifically. I kind of wanted to get your perspective on, with regards to policymakers and governmental organizations, how do you think that they prioritize that statistic when making healthcare policy related decisions? And do you think that they prioritize other healthcare related statistics more, and how could that contribute to kind of gaining a better understanding of universal health coverage and understanding people's accessibility to healthcare more?
Yeah, thank you very much. Very great questions. Okay, so let's start by comparing indicator deaths and DALYs, for example. You see that if you look at deaths, you look at the number of people who are dead, but you don't have what I would call the global burden on the community. When you look at the life years lost, you add something to the measure of this global burden, because you know that it's life years of productivity, for example, that are lost is because people were dead or people have a disability, okay? So it's a more better appropriate, it's more appropriate to look at DALYs than to look only at death or at disabilities, because it's the impact on life years. And if you look at COVID, what happened with COVID, the number of DALYs that have been lost at well, definitely it has an impact on the society. Okay, so now, do people use DALYs, CALYs, life years lost, that kind of things when they design their policies? If it's done by professionals, if it's done by people like CDC, no, they do. They use it and they know the value of these indicators. If they are just politicians who are just, doing policies out of, I would say, out of nowhere because they want to please some people or they want to do this. No, they are not using any scientific basis for their policy. And what I think is that if we want to train students to become good policymakers in health, we need to show them what are some policies. But most of all, we need to provide them with skills and tools to design these policies. Okay, so I'm a firm believer of tools and skills, and I'm less a believer in talking around something. So it's why in my classes, I try to provide students with tools that they could use during their career.
Our next question is going to be one from the chat. Sophie asked, do you have any advice for how to use this information in our future careers as young professionals in the public health space?
Sorry, there was some return.
Yeah, I can repeat that.
Yeah.
Sorry, can you hear me better now?
Yeah.
So our next question is from the chat. Sophie asked if you have any advice for us on how to use this information in our future careers as young professionals in the public health space.
Okay, so how to use this? In order, it's what I said, in order to be a good professional, you need to have skills, you need to have tools. And so what I would do, and I joined the World Bank, I didn't have all the skills and the knowledge that I teach now. I would have liked to be more prepared to design projects, to implement projects. So try to focus on skills and tools that you will need as a professional in the health sector, whether as public health, global health specialist, unit. What I can say also is that in the world, most public health or global health specialists are both MDs and public health or global health specialists. In America, it's not a requirement. And during my professional life, I learned a lot for the public or global health specialists that were MDs. And as a health economist, I knew more than the public health specialists or global health specialists that were not MDs. So that's just what I can say at this point. So if you want to design good projects, you need to know a minimum of epidemiology, of pharmacy, pharmacology, all these things, because otherwise you will not design a good project because you don't know exactly what is needed. So I hope that I answer this question.
Yes, thank you. I just wanted to point out to everybody that we are running out of time. So let's keep these questions brief. I'm going to hand it over to Noah now, and then after that, maybe one more.
Yeah, I'm going to be fast so that Jero can ask his question. Go ahead.
Hi. Well, yes, again, thank you so much for your super informative lecture and for your time as well. My answer or my question kind of goes back to some of our discussion of how to improve health system performance, specifically in regards to incentives. So as you discussed, healthcare providers have the incentive to provide treatment to patients because they, want people to come back to get more treatment. And there's not really an incentive for preventative care. So my question is kind of, do you think that there is a world or is there anything that we can kind of do to design incentives that would encourage providers to encourage preventative care?
Yeah, I can give several examples. I'm going to limit my answer to one of these examples, is what is called result-based financing. Okay, so if you pay people on the results that they have, then you will be able to develop some skills. Example, in the healthcare in the UK, if their patients stop smoking, they get bonuses. Okay, so we can develop this system on, okay, you are going to be paid more if you have results. And the results you have to define. And so in this case, it's smoking. You have your patients have less less diabetes. You lower their level of sugar. You have many ways where you can target elements where you want people to work on. Okay, so your providers are going to focus on things that give them some bonuses.
Okay, thank you, Dr. Turbat. Jerome, whenever you're ready, you can ask your question.
Very good question, Noah. Thank you so much for the floor. Very, very informative presentation, Dr. Turbat. Thank you so much. So my question is quite simple. Noah actually introduced one of the best subjects. I was about to ask, since the United States actually missed the turn toward effective care and equitable universal healthcare coverage, with the high bills, too many bills and everything else. I just wanted to say, given also right now that the NHS in the UK is also in trouble, shortages, staff shortages, and also long wait time, what do you think developing countries should take lessons on regarding the next step, designing a resilient healthcare system to avoid certain pitfalls, such as the NHS going through right now? British people have been super proud of the NHS for a long period of time. And right now, they've been also thinking about privatizing it. And that would be the worst case scenario, in my opinion. So,
yeah, but it's why I think that having the financing of the health system and the delivery of the health system under the government, it's not a good way of doing that. First, because as you know, when you finance through the government budget, all the funds in the government budget are fungible. Fungible means that you can use these funds for whatever is needed or you want to. And so what we see is that in the case of UK, when you have, let's say, Labour kind of government, but you have a lot of funding for social sectors, including health. And when it's a conservative one, you have not enough. And therefore, you have all these problems that you just mentioned about shortages of everything in the UK currently. So the budget should be independent. And it was a social security system And if you remember, the social security system has been defined by Bismarck, the German chancellor, to unify the Germany, but it's independent. But sure enough, the government, as it say, has some veto power and all these things, but it's not the government budget, meaning that the funding which is in the social security system cannot be used for something else. You cannot decide to use it for wars or whatever. It is for health and nothing else. So it's why I think that this system where you have public financing, but independent from the government budget, and a private delivery, mostly private delivery. For example, people always think that the French system is socialized, but there are more private providers in France in percentage term than in the US. So I think it's what at this time I would say it's the best system that I can think of.
So I'd like to thank Vincent for a great introductory seminar to this series. We're going to approach a lot of these issues in subsequent lectures and subsequent seminars, and there'll be lots of opportunity for both students and guests to approach these issues again. I'm sorry we didn't have time to go to the outside questions. With that, thanks to everyone, and I'll turn it back to Abba for last words.
Thanks, Dr. Myers. Yeah, thank you so much, Dr. Turbat, for your informative presentation. I know we all took so much from it, especially since we all come from different backgrounds, and we're really eager to explore these interests and be in your class next semester. So again, for the class, it's being encouraged that we reach out to these speakers for more questions if you have any. I guess I can give his email address to you guys and we can go forth from there. So I guess that's everything. Thank you guys so much.
Okay, thanks everyone.
Thank
And
you.
we'll see you next week, same time, same place.
Okay. Thank you very much. Bye-bye.